Welcome to the PTR Physiotherapy Rehab Podcast. My name is Warwick Schmidt, and in this podcast we interview subject matter experts, authors and elite athletes to help inform clinicians and patients and generate discussions around sports, rehab, health and how to get people back to their best. We hope you can take away some content and use it in your practice. Welcome to the PTR Physiotherapy Rehab Podcast, where we talk about MSK rehab topics, which will hopefully improve your insight and rehab with patients. Today we have a really good episode lined up. We've got Matt Anthis, the rowing physio, and Beccy Moneley, recently married. So I'm going to ask both of you just to introduce yourselves, your background, how you got into chiro, how you got into physio, and then the episode today will focus on Beccy as a patient, and the theme will be about how do clinicians take injuries and what can we learn from that. So Matt, can you just introduce the listeners?
Hello, I'm a physiotherapist. I've been practicing for nearly 10 years now. Started out with my interest in physio because I was a rower myself. I had a back injury when I was about 15, 16 years old and didn't get particularly, good sound advice about what to do while I was injured. Just got told to rest and given a spiky ball and told to swim, and at the time had no interest in swimming whatsoever. So essentially lost interest, which was a bit of a shame because I had ambitions to push on as a lightweight rower. And yeah, that all came crumbling down. So I enjoyed the thought of just having an active approach as a physiotherapist and wanted to make sure that I could give that to my patients as well. So I've done a little bit of extra upskilling as a wellbeing coach, and I've also done my master's and currently doing a PhD in hamstring injuries just to add a little bit of variety. Not something you often see with rowers, but still something that I'm interested in and just adds a bit more scope to what I do.
Amazing. Beccy?
So fairly similar story. I was and still am a rower and had a back injury when I was about 16, and actually saw a chiro and really helped at the time and thought, yeah, this is cool. This is what I want to do. And then it kind of branched out from there. And now I've been a chiro 7.5 years, treating a mixture of everybody. I mean, my specialty is actually pediatrics and pregnancy, but being a rower myself, I still see a lot of rowers in clinic. So
Excellent. So today, if we can, well, today already here, but if Beccy, if you could start off your injury history. So can you walk us through? You had what the injury was and where did you start to feel it?
I mean, it started back when I was 16. So that's 2008. And I had what we thought at the time was a back injury. I had all the usual stuff of nothing was helping, had a cortisone injection, had an MRI. There was a small disc bulge at L5. Kind of rested, got back to training, but never really properly, and ended up taking a break. And then qualified as a chiropractor, moved back to Henley, came back to rowing, had probably a year of no pain. And then considering it's nearly, 10 years later, exact same injury, came back, low back pain, more so in the hip this time, and ended up having another MRI where they found the labral tear, but everybody still thought it was the low back, and it was actually one of my colleagues at work that said, I think it's your hip. But I think some of the complication is the fact that because I'm quite hypermobile, and most people would look at it and go, your hip range of motion is fine, so it's not the hip. And it was only after I kind of pushed for an MRI of the hip rather than the low back that we found the labral tear, basically.
So quite a long time before they picked up the hip then.
Yeah, because I think if someone had maybe done that when I was 16, it probably could have been a bit of a different story. But it just kind of kept reoccurring, and I guess that's why. And the disc was probably more a symptom of the tear, which you see quite a lot in rowers as well, that the labral tear comes with the disc and vice versa. So, but yeah, and then I had surgery on it a few months later. It was quite cool. So the guy that I saw was Rishi Chana, and he was a hip sports specialist, and he did sort of like a stem cell repair with it. So mixing with pig's collagen, and the outcome was really good. So I've now had 2-3 seasons of no pain. So
it's gone fast, isn't it? Because I remember it feels
yeah,
like just the other day you were going through
so
surgery.
May, where are we now? So it was May 2021.
Okay.
So it's still definitely a weak area, and I think the hypermobility aspect, and I think sometimes as clinicians we make the worst patients. So I can say that my rehab hasn't been perfect.
We'll go through rehab a little bit later on. Reps and sets, everything in detail, please.
Yeah.
Matt, can you just shed some light on is that something you find quite common, that we overlook the hip and go straight to the back with rowers?
Yeah, look, that area is very very complex, and I still think there's parts of it that we're figuring out. I think when we talk about referral patterns and that sort of thing, it's it can be really tricky. You can get referral patterns from the joints, from the hip, obviously. You can get sacroiliac based pain, so pain at the base of the spine, and often the signs aren't necessarily very obvious. But I'm really interested, Beccy, what was it that made your colleague think that it might be the hip?
I think it was the fact that she could see the difference in the mobility left and right, and more this time, sort of in this 2021 period compared to when I was a teenager, there was more pain coming into the hip. But like you were saying, actually, most of the pain was in the SI area. And you'd kind of, especially as a chiro, everyone would be adjusting it. And yes, it needed it, but it was almost like that was just the weak spot as a result. And there wasn't necessarily any referral pain down the back of the leg. It was more at the front a little bit. And then obviously talking about it from a rowing perspective, it was always much worse when I was doing sweep rather than sculling. And I think obviously being stroke side, I was compressing into that right side more so, and there was a lot of imbalance. So
could you just, for those who don't know rowing, give a little just a definition or what the difference between those?
So sculling is using 2 oars, so it's a lot more symmetrical. And then sweep is using 1 oar. And then I was stroke side. I mean, that's a whole other topic about teenagers rowing one side from young, because it creates a lot of issues. But if you're twisting into that right side, then there's a lot more compression through that area. And if you're not doing it particularly well as well, and the core and the glutes and all the rest of it, then you're putting a lot of pressure in there.
Yeah, I think. Did you feel at any point that they weren't doing a good enough job with the physios? Or was it something in terms of your side? Was it frustrating that it was you didn't get to the bottom of it, or?
Yeah, I mean, I saw a physio as a teenager, and I think I got that kind of generic experience of do more core, do more glutes. It's a weakness. It's because you're rowing 6 times a week at 16. That's the problem, rather than looking deeper into it. It was only kind of, I think it just takes someone to take a little bit more time with you to look into it and actually look at where it's coming from.
Matt, would you, in terms of sort of outcome measures, what in your clinical experience with rowers, you've got somebody who comes in like Beccy, who's everything's screaming at the back. Is it something with rowers that you, because there's so much prevalence and link between the two, would you suggest clinicians kind of they screen the hip as well then, and we sweep it all into one assessment, or would you?
Yeah, if I think about the screening that I do sort of routinely, like I have people come and see me who just want to know how to avoid injury, for example, and I do pretty much the same screening for almost every athlete I see. Depending on time allocation, that sort of thing, there might be some elements that I don't look into as much, but as part of my normal screening, I'll usually do a test called the FADIR, or it's just a hip screening sort of test that you might do. Typically, if you're looking to exclude the hip, and we probably use it a little bit more with knee pain in adolescents, but at the same time, it's still a good one to use for back pain as a whole. And I'd be looking at just how the athlete might respond to repeated sort of back-based movements. And if none of those movements are really recreating the same symptoms, then we might be looking for other sources of other regions that might be creating that pain. So if we're repeatedly bending forward and nothing's really, like the athlete just doesn't, you're just not getting that exact type of pain, you might look at other areas, and that would definitely include the hip. It's a fairly quick test to administer, and it's actually quite effective at ruling the hip out of consideration. It doesn't necessarily tell you exactly what's going on if that test is positive, but it's a good test to use potentially as part of a cluster to give you an idea whether it's a potential source of symptoms at least.
Did you feel with your pain, Beccy, I was going to ask Matt about whether in terms of strength testing, so we've got the kind of the joint screening, linking with the back, but were there any strength deficits that you were was it really obvious that you were weaker on that side, or
yeah,
were you quite strong?
I think on my right side, in general, everything was weaker. So the glutes weren't activating, the hamstring was weaker, the quads were weaker. And it was actually, I saw a really great physio post-surgery, and he kind of noticed that he could even see like the quad definition difference. And I think if you see kind of like a standard physio that's not looking into things from a sports perspective, you're still going to be strong comparatively to the average patient. So it kind of needs that comparison, I guess. But yeah.
Did you help guide the assessment at all? Was it as a clinician?
Yeah, I mean, it's hard, isn't it? Because you're like, I think you should do this, I think you should do that. But then you can get in such a hole with yourself, if you see what I mean. Like, you overthink your own care, I think, more than anyone else's, because you want to help yourself, right? But it turns into such a mess when you keep trying to fix yourself, I think. So it's kind of hard to let go of control, but you kind of need to once you find someone you respect, I think it makes it a lot easier.
Did you find, in terms of that clinician's relationship, was that respect quite important rather than just their CV and how kind of smart?
Yeah, like I think obviously having a good, if I'd seen someone like Matt, that would have been ideal, but it's quite hard to find someone that understands rowing as well. I think there's a lot of sports physios that are great with ball sports, like football, and with runners, and it's kind of just different. But this guy, I mean, they had a great facility, and he put me on the erg, which is the row machine.
I was going to ask about whether both of you would like assess somebody on erg anyway in the clinic, or whether you have one.
Yeah, and like having a look at movement patterns, and you could just see straight away that he knew what he was doing.
So a little bit like how runners, we look at them, do a slow-mo on the treadmill. You do kind of the same thing. Matt, in your experience, do you do something similar like that? Have them on the erg?
Yeah, well, I've done a bit of both. I've done some without, some with. In an ideal situation, I will. It's just clinics that I've worked at that I just haven't had access to one. But if I don't, then I'll usually get the coach to give me some footage. I just try and work with the coaches and the athletes as much as possible. And I think it's important to keep that communication open. So I often ask most rowers, like, what is your coach trying to work on with you? Like, what are you hearing most? And sometimes those cues are really helpful because it lets you know that, they're shortening up at a particular, maybe as they get fatigued, they shorten up a little bit, which is a fairly standard sort of response. I'm thinking of something quite generic here, but it might indicate that, they might need a bit more work on the mobility to get their baseline mobility up, for example, or maybe their strength's down, they're getting a bit, their endurance is a little bit low. There's a lot of reasons, but it might just help solidify some of my theories and help bring it a little bit more to life. So, because essentially we're looking at someone for potentially a maximum an hour, 45 minutes. So I want to get as much information as we can. And I think the clinical testing that we have doesn't necessarily cross over that well. So I often tell people, like, there's no test I can do in the clinic that will perfectly replicate the rowing stroke. It's just not really that feasible. The erg gives us some assistance, but there's definitely different parameters and variables in the water that can change how someone rows, and fatigue and also makes a huge difference as well. So I usually get a little bit of footage at the start of the session and a little bit of footage towards the end, so we can start to get a bit of an idea whether fatigue's playing a bit of a role and how that might change things also.
What are you? This is for Becky as well. What would you, if you're looking? I mean, this is broad spectrum. Obviously, we don't have an example now. But what would, if somebody who's never worked with a rower, they've got some image footage. What ballparks kind of signs? What would a physio be looking for? That means there's compensation. In terms of, is there more trunk? Are they reaching further? Is there more lumbar? What would be the flags that you go, right? I'm going to work on that X, Y, and Z. Just putting a little bit of pressure on you there. So
yeah. I look at hip range. Like, it's probably the most important thing that I look at. It's like you need 130 degrees of hip flexion, and with a hip-based injury, that's really challenging. I think also just being able to get to a good having good pelvic position is really important as well. So I think for a lot of adolescents, just understanding pelvic tilt and that your pelvis actually does move is really helpful. Being able to sit up on your sit bones, for example, something that a lot of adolescents struggle with, just owing to really poor hamstring flexibility. And that's something that can be changed relatively quickly, but also bearing in mind that actually growing will reduce the rate at which you improve your flexibility. So often I get parents coming in with their son or daughter saying, essentially, like, I've given them this stretch, hasn't necessarily changed, but they've grown as well. So the parents are sometimes a little bit hard on their kids. And I just say, look, you've grown. You haven't necessarily not been doing your homework. It's just you're growing at the same time, which makes it a little bit tricky to actually get those flexibility improvements.
Did you, in terms of Becky, following on from what Matt said, what sort of core work or kind of what rehab? Sorry, but did you do before surgery? Were there two or three things that really helped you to try and stave off surgery?
I think the stuff that really helped pre-surgery, I think, was a lot of like quad and glute activation stuff, and just still exercising, because I think it's very easy mentally to kind of go, well, if I'm having surgery, it's like give up time almost. But I kind of was rowing up until the surgery as well, and I think that probably helped coming back from it. But I think it's interesting when Matt's talking about adolescence as well with the stretches and stuff, because I don't know what it's like now, but as a teenager, I don't think coaching, there was a huge kind of focus on core and mobility and stretching. It was kind of get the training done. Core is a waste of a session, and I think that's changed a lot now. But the rate of injury when I was a teenager in rowing was insane, like absolutely insane. So
no room for kind of a warm up. Cool. I mean,
no, I think we had a Pilates teacher on a Sunday, one session for like a month, and the coach then decided that was waste of time. Let's get back out in the water. Yeah.
That's interesting. Do you think that that's helped in your experience, Matt, that coaches have changed when you've worked with younger athletes? Or
yeah, I think the paradigm's shifting a little bit, which is really good to see. I think certainly on the warm up, and maybe not so much the I guess the warm down front necessarily, but and that's kind of where I'd like it to be honest. I think as a whole, the like mobility balls or spiky balls, whatever you want to call them, are really becoming quite popular. I think a couple of years ago there was a squad I was looking after, and they had a bunch of bands, and they said, "Yep, we're going to use the booty bands for at least 2 minutes before we get on the water." So a bit of a variety of exercises, which I thought was pretty cool, and it was sort of that good rowing. hardcore, like, yeah, let's build some culture here, which was really awesome to see. I still think as a whole, like, we've still got a way to go as far as like, coaching education, but yeah, really good to see a lot of coaches coming to the party and just getting on top of these things, because I think they can be really helpful.
It's getting ahead of it, yeah. With your journey through the injury, so you put it off for as long as you can.
Mm-hmm.
What was the point where you made the decision? What made you take the surgical route? What led you to that?
I
Makes
think
sense?
it was, I mean, obviously a surgeon is maybe a little bit biased, but actually seeing the scans, and it's big to know that it's not in your head as well. And I think actually seeing the damage and reading the report kind of gave me the confidence that it was worth surgery, because obviously as chiropractors and physios, that's what we're always trying to avoid. But actually through my own experience, I've been a little bit more positive about surgery to some people, because I think if you do it right, you can recover really quickly. I mean, I had the surgery in May and I was back on the water by August, which
That's
I think
impressive.
isn't a bad recovery cycle.
No.
And was sort of doing like spin classes and swimming and stuff within 6 to 8 weeks. So it can be quite positive.
Yeah, that's. I think that's it. With more experience, you start to, your walls come down a bit. You start to be open a little bit. We are very much anti, as much as possible. But then you see enough patients, and you start to get, it's not a complete black and white.
Because you can feel, I think as a physio or a chiro, you can almost feel like you failed if they get to the surgery point of view.
There's a little bit of that, like a bit of pride. You got to suck it up and go, okay, well, all of my tricks and fancy rehab programs didn't quite get the job done, but I guess.
Yeah. And I think obviously a tear is a tear, and that's not going to heal itself, but there's many people that still train with a tear if they can kind of build the musculature around it to protect it. But if you've tried that, then there's still pain, then it's something to look at.
What did you feel about surgery? Did you feel that it was coming and then you accepted it, or was it quite a shock that you said, right, well, I'm going under the knife?
I think, to be honest, after having nearly 10 years, I guess, on and off of the same problem, to actually have what I felt was a resolution for it was really positive. And I was kind of like, okay, let's do this tomorrow. And let's just get on with it and get it done. So, but I think also having that knowledge as a patient of what it means and understanding the scans also helps, because I can imagine if you didn't understand, then it could perhaps be a little bit more scary.
No, that's a big deal. I think the mental side of it. And then, do you think that that the injury itself would have just stayed the same? Do you think that would have got worse if you didn't do the surgery?
Yeah, I think I'd also got to the point where I had pain while I was working as well as rowing, and I think that's when it's affecting your sleep and it's affecting your work. I mean, sometimes you feel like rowing's more important than work, right? But
I don't. So speak for yourself.
Yeah.
I don't like going on the road if I can keep off it.
But I think once you start seeing that, like your livelihood could be affected by it, and it was getting to you mentally, it's just you're ready for a change.
So that started creeping in for you.
Yeah.
Yeah. So do you think that's something you could advise clinicians? Maybe that's like a tick, part of the tick box to say, look.
Yeah,
let's move on from.
I think when I speak to patients, I kind of say only consider surgery. I mean, whether this is a knee replacement, whether this is a hip tear, whether this is a discectomy, I kind of say once you've tried everything and you still have pain that affects decisions of what you do every day, like say if you go, I'm not going to go to that because it's going to cause me pain, or you kind of miss out and opt out and it's there in your life every day, I think that's when you have to consider surgery.
It's interesting. It's a big change mentally for that. I just wanted to. I've been very antisocial looking at my phone, but it's only because I've tried to find a study that I found before the podcast, and I'm going to butcher the name, but it's Wedatalake et al. 2021, and it's an association between hip joint impingement and lumbar disc disease, which essentially is exactly your case, where they found of their population, 85% of the rowers had a cam morphology, the neck. 95% of the group that they looked at had labral tears, but only 50% had the groin pain. 85% of rowers had one disc, one disc injury, and 95% had a history of back pain. And essentially, the paper goes on to describe your case, which is essentially everyone jumps on the back. But actually, the reason being is that as the cam morphology develops, the flexion point becomes further back, and instead of flexing at the hip, they start flexing at the back, and actually the kind of horse before the cart sort of thing. You've got the hip leading that. But just when I read that paper, I don't know whether you found that with your work, Matt, that so many rowers have such pronounced labral joint injuries. It's almost like the same as football population, really, the adolescent football population. Is that sort of something you see as well? A lot of the youngsters with that sort of those percentages?
Yeah, I think particularly in Australia, we've got a lot of different football codes, and I think that's where potentially some of these, I think they're finding some of these FAI type things are sort of manifesting just from your kicking sports, where you're kicking your leg across your body, and it's sort of seen as this adaptive sort of process where the body tries to create a bit of a buffer zone, and I guess to a point it ends up being a bit of a risk factor for these labral injuries potentially later on. I think the interesting thing with that study as well, and just to clarify, was it looking at asymptomatic or both symptomatic and asymptomatic populations?
It was lomodystosy. I think it was symptomatic. So I think they were looking at again. I'm stand to be corrected, but they looked at the. Sorry, here we go. No, the findings were the high prevalence of asymptomatic labral tears. I think they looked at a group of rowers, to be honest with you. I think from the paper, it wasn't all symptomatic. They looked through the history, they did the scans and the imaging, and then tracked the athletes. So, yeah.
Yeah, and I think that's something that we do sort of see across different populations as well, which is really challenging, is that some of these findings can be sort of incidental as well, which just makes the diagnostics potentially a little bit more challenging. I think I think they have done studies in Australian rules football where they've done a cross section of I think fairly new recruits to see whether they have cam or pincer lesions, and they found that a lot of them have been incidental, which is really tricky to see whether someone's going to potentially develop a labral tear in time. But I think I've got a stat. I can't quote it off the top of my head perfectly as far as where it's from, but have seen a 40% incidental rate of cam and pincer lesions, so FAI, which is pretty high. Yeah.
It's something, as you said, that conundrum where you want to avoid imaging, but imaging becomes necessary in symptoms, and then it was probably something they would do. And then this is for both of you. If you have, how would you educate the patient on managing an asymptomatic cam lesion? Is there in terms of educational points for patients?
I think obviously keeping the mobility and the flexibility in the hips and the strength. I mean, it's maybe I say to most rowers, if you can avoid back squats and do front squats instead, because you're activating the core, you're not getting that same compression. And if you have got, for example, FAI going on, whether it be cam, pincer, both, because I had both, and I think that's quite common as well in rowers to get a combination of the two. And even to this day, every time I squat, I still get that lateral shift over to the left. And I think you're going to get that if you've got that impingement. So if you can do much more dynamic sort of one-legged stuff as well, that's probably going to reduce your risk of overloading it and creating more of an issue. But I don't know what Matt would say.
Yeah, I think that's all very very reasonable. I think at the end of the day, you're trying to mitigate as much as possible. The pathology is there. It's not necessarily something that you're going to, I guess, fix or necessarily change with your hands-on management. Like, it's a morphological thing. So I think for the most part, we're looking to mitigate. So personally, I just look to make sure that their cross training doesn't irritate as much as possible. Like we know that rowing is going to lock them into a fair bit of flexion. So I just get them to make sure that their gym work and everything else isn't going to sort of irritate that anterior hip region. So yeah, I think similar sort of modifications to what you were talking about, Beccy, are really reasonable, and just looking to get as much hip control and stability going as you can, just to just take as much pressure off the joint as possible.
Just out of interest, cross training. Somebody wants to advise a rower how to keep their fitness. What machine are you going straight for? What do you think is the best? This is more personal opinion, I think. Isn't
the
it?
go-to for rowers is probably always cycling. So we have bike ergs at the club, and you'll always see those full of people that are managing injuries. But I mean, personally for me, I found swimming really, really helpful. I felt like that was actually helping to open up the hip, because we spend so much time in flexion, right? You're sat in flexion when you're rowing, you're sat in flexion when you're sat down and you're working. The bike, I think, is a mixture for people. Some people find it really help. Some people, it can make it worse. Again, having the bike set up properly, it's probably a huge thing. I mean, I found that if I could sit on the bike upright, I was fine. If I went out on my road bike, where there's probably more balance, more flexion, you're probably going for longer and you can't stop as easily. I think that tended to irritate it a little bit more. But I think rowers will always go for the bike first. There's not many rowers that would choose running.
No, I guess
we're not natural runners. No. Yeah.
What about the cross trainer?
Yeah, I think the cross trainer is really good, but I think in the standard rowing club, you won't have a cross trainer in the gym, and people want to try and stick to their usual routine as much as possible. But our coach recommends swimming quite a lot to people that are injured, and I think that's really good.
Yeah. Didn't you enjoyed swimming, Matt? Didn't you? When you were told to swim?
Not at 15. Not at 15.
Yeah, those morning sessions are not the one. I stopped swimming when I was 16 because the coach said morning sessions or you quit. So I was like, right, I'm done. Oh, that's my swimming career done. So yeah. If you get any insight to that, Matt, sort of apart from the bike, have you found anything else that gives the same? Because rowing's really good. I know it sounds obvious, and I'm teaching everyone how to suck eggs, but the rowing machine is horrible for the cardio. But is there anything that you found that can still push the heart rate as high?
Yeah, I think Beccy nailed it. It's about the setup on the bike makes a big difference. I think if your seat's particularly low and you're really driving your knees up above the level of the hip, or not necessarily above, but I guess higher than you would if you were a little bit potentially higher up on the seat, that can make a bit of a difference. I think sometimes you can swim, like if it's really uncomfortable, just keep it to your freestyle, avoid the breaststroke, and swim with a pull buoy between your knees or your feet if you're really struggling. Just watch that you're not compensating too much by doing thousands and thousands of meters just using your shoulders, because we probably don't load up the shoulders that much as rowers. We do, but not that much, and you could end up with some cross training injuries, which are just it's never good when you've got an injury and you just end up picking up another one through rehab, just being a bit overzealous.
Yeah, a little heart sinker, isn't it? Yeah. With the kind of the final component of you getting from post surgery to on the water, I'm going to ask about rehab. The best rehab exercises for rowers, or kind of for glute core strength, and then the final bit would be discharge outcome measures. So if you talk to us about, it doesn't have to be detailed, but like what rehab exercises really gave you bang for buck? What do you think really worked for you?
So I actually think one of the things that worked the best at the start was the is it called the Compex machine?
Yep.
Where you have the electrodes, because it's getting that activation back first, and otherwise you're firing all the wrong stuff. So I was using that a lot on the quads and the glutes. And then from there, I had a lot of like seated, banded, sort of both for the hip flexor and for the quad extensions and lifts.
Yep.
And then sort of, like the classic glute bridge,
Love a
clams, all the rest of it. And obviously making sure you're in the right setup for it. Because I mean, I'm sure you guys have seen it before, where you get a patient to come back and show you their exercises and everything's flailing everywhere and you're not really activating.
Yeah, they're doing press ups or something.
Yeah.
Not even doing the exercise. Yeah.
Like there was nothing crazy, I think, all the sort of standard stuff. And then it was a general rule that I tend to give rowers and gave myself was that you shouldn't go out on the water until you can do at least sort of 12 to 16K comfortably on the rowing machine. Because obviously you can stop when you're on the rowing machine, but if you're out on the water and you're sort of 6K from home, then you've got a problem.
And how did you break down getting onto the rower and building the tolerance? Because I think with the work in the military, do a lot of running build up, and there's absolutely no scientific data to show you should do X, Y, and Z.
Yeah,
everyone's different. Someone can go off and do a run for half an hour on their first run, and some people need 1 minute on, 1 minute off and stuff. So how did you do that one?
so I think the natural thing was I wanted to get on and do a normal session. Straight in and see. But I sort of did like 5 minutes on, 5 minutes rest, 10 minutes on, 10 minutes rest, and built up. And I still remember, because I always had the same thing right from 16 to pre-surgery, where about the 15-minute mark on an erg would be where I'd start to feel the pain sort of in the SI joint, and it would slowly spread up the back and around the front. And I still remember getting off the erg after doing 20 minutes and feeling no pain for the first time, and like taking a selfie, and I still remember that moment so clearly. And seeing the time pass and being like, whoa, it still feels good. And I think just slowly built it up from there. I mean, like anyone, I probably did too much.
Classic.
Because it felt good as well. And there was definitely, it wasn't a smooth journey. There was setbacks, and the classic of as it starts to feel better, you do less rehab. And I would probably admit even now, today, there's still a weakness on my right side to my left. And I still try and incorporate into normal weight sessions and going out in the water, glute activation before I go, a bit like Matt was saying about using the booty bands. And that 100% makes a difference.
Nice.
But it's not perfect, and I don't know that it ever will be.
What were the setbacks? What was it? Flare of pain? Was it something that you? Yeah.
So I think, trying to remember now, I got quite a lot of knee pain in the recovery, and the surgeon said that's fairly normal because you're kind of using everything differently again, I guess. But that kind of slowly disappeared. I also wonder whether the knee pain was I was doing quite a lot of like spin classes, and which is different for your body.
Sure.
But then that kind of settled, and now it's pretty solid as long as I'm careful.
Nice.
Yeah.
Matt, any kind of the rehab exercises, and then how would you break down the build up on the erg? Any specific nuggets, exercises that you really like for rowers?
Rowers wise, I take the same approach I take for the gym, in the gym for a lot of rehab. I think you generally start with your double leg exercises, work towards a split squat sort of routine, or like a lunge or something like that, or a static lunge, and then start to go into more of a Bulgarian split squat. So you've got the back foot elevated, so you have a little bit less assistance with balance, and then work towards a single leg exercise, or a single leg squat. And I think what you're looking for is just really good mechanics to start. So making sure that your hip, knee, second toe are all in the one line. You're looking at, primarily what are the goals at the end of the day. So if it's a quad exercise, let's make sure we're loading the quad. So let's bring the knee a little bit past the toes, which probably 10 years ago everyone said not to do that. But I guess, social media and certain personalities have made it a bit more popular, but nonetheless, like just making sure that keep primarily the big muscles doing what they need to do. So quads and glutes, hugely important. So I might look at getting some hip thrust going or hip bridges. Just on your point before, Beccy, I was just thinking about, can't tell you the amount of time that I've told someone, oh, yeah, you're going to do some glute bridges, and they start to do the yoga variation, which is sort of where you put your hands up near your head and try and arch your back up into a big sort of bridge. And far from what we want to sort of achieve there. Nonetheless, we look at so strengthening rotators, but mostly quads and glute strength, I think, is hugely important, making sure we got some hamstring assistance. So I think you're working towards a Romanian deadlift, but just probably not avoiding too much deep flexion there. So you're probably capping the amount that you're doing, or the load, or the depth, essentially. So not looking to actually go all the way down, and then really focusing on pelvic tilt control and just awareness through the stroke. So I guess that sort of filters into your core work as well. I look at things quite simplistically. I think you've got an anti-flexion and anti-extension sort of movement. So anti-flexion might be like a back extension type movement. Anti-extension might be like your dead bug, which is hugely popular. And then looking at a little bit more rotation and side flexion control as well, just to keep really solid muscle control and awareness. I think sometimes you need to mitigate where the flexion's occurring and making sure that because the hip's still potentially a little bit inhibited, that they're not starting to load up the lower back as well.
I'm going to be really difficult here, but in terms of discharge sort of outcome measures, I know it sounds really black and white, which it certainly isn't, but you might maybe feel like ACL rehab tends to lead the way on lower limb outcome measures. So you've got 90-95% limb symmetry, certain percentage of body weight leg press and stuff like that. Do you use any of that type of for the elite rowers where they need to be pretty robust? What sort of stuff do you do with that?
I think probably try and do a little bit of isometric testing just to get a sense of, I guess, what the comparatives like between sides. I think the data is really lacking, and that's probably what makes it a little bit tricky. I think there's a wide array of different levels of strength, particularly in rowers. And I think if we were to look at even knee extension strength across from like a new rower at sort of anywhere from 10 to 13 years old to, gold medal winning crew member, there'd be a huge variation in how much quad strength or glute strength or however much they can develop. There is a test that developed by one of the previous Rowing Australia physios. It's a sit to stand test. So it's a little bit different to what you'd sort of expect. So you get into a really, really low step, and what you've got to do is stand up from the step without your knees drifting forward, and you've got to do it all in the one motion. So it's really tricky because what a lot of people want to do is use their quads to just sort of muscle through it, but they've actually got to use their glutes by pushing through their heels. And I did a screening probably 1 or 2 months ago, and I think there was only 2 out of the 40 odd that I screened that could actually do it. Fortunately, for whatever reason, I can demonstrate it. Otherwise, I think they'd believe that it's just not achievable. But that's a really good test just to look at glute function. It also gets you into the compression position at the catch as well. So it is a little bit on the functional side as well. But I think other sort of exit criteria would be your hip flexion test, single leg squat, and you might do that off a box as well, just to look for hip and trunk control as well.
Excellent. And your breakdown on the erg build up, is it kind of structured, or are you doing it quite per athlete?
Yeah. Look, my philosophy is really. You ask most of my patients, I keep the erg in pretty low regard, to be honest. I use it as a tester, but I'll often try and build up on water as much as possible. The reason being is just we know that there is some additional forces at the catch position that can load up the lower back a little bit more. So I'll use it as a little bit of a tester, because the last thing you want to do is get the boat on the water. You start your warm up and it's already a disaster. So I think sometimes it can be helpful. I'm not huge on it for lower back pain, but I think in the context of hip pain could be a little bit more helpful. Again, just for the symptomatic side of things, but I'm not getting people to do masses and masses on the erg to start off with.
Sure.
I sort of use it potentially a little bit later on once they're on water volumes up to par. And I would usually just get them to hang somewhere near the pontoon and give them really firm parameters around when to head back in. So I say, like, look, a 2 out of 10 on the pain scale is somewhat acceptable. If you're getting a 4, you need to stop. If it doesn't go away, so it doesn't go down to a 0 or a 2 within a matter of somewhere between 5 to 10 minutes, then you're making your way back in.
Excellent. In terms of the hip symptoms, do you have any more that still linger, or you said earlier that you're completely pain free? Do you still get a little bit?
I still get, if I'm not careful with it and I'm not doing all the things that we tell everybody else to do, then it will definitely flare up. So for example, we went on training camp last year, and where that's upping it to 3 sessions a day, sleeping in a different bed, traveling on a plane, all that kind of stuff, then that can give flare-ups. I usually find it's not the rowing so much that will flare it up these days. It's things like wearing heels for a long time, or traveling for a long time, sort of sat still on a plane where the hips, because as a tall person sat on a plane, it's not an ideal situation. And then I really notice the difference if I'm not doing my weights. I think as long as I keep up the weights, then I can handle the water and the ergs. Or last year when it was flooding a lot, we spent a lot of time on the erg and not a lot of time on the water. And I think within a month, maybe half the squad was on a bike. So it just shows that a bit like Matt was saying, the erg is actually, it can be a lot worse than the water.
That's good to know. Again, like it's probably common sense for you two working and living rowing, but if you got physios, you don't know it. We would probably thrash. I would say, like, well, we're going to work on your 2K time. We're going to get you doing 10K on the erg, and maybe I'd be causing more issues if they can get on the water. Then you'd say both of you go get on the water first, speak with a coach, and get them. Yeah.
I think another thing that's really good for rowers if they have access to it is the RP3, which is like a dynamic erg, where I don't know how to explain it. Matt might be able to explain it, but no, but the whole frame moves with you, and there's a lot more balance involved, so it replicates the water a lot better. And I always find if I have any kind of niggle, if I do a couple of weeks of sessions on the RP3 instead of the static erg, then that can deload a lot.
Okay. Matt, what's the RP3?
Yeah, it's definitely edged ahead of erging in my books. And again, I'll just say, like, this is sort of my approach, I guess. But I like to sort of look at the evidence and that sort of thing too. But yeah, I think the RP3 is probably the superior one, if I can say that, as far as like off water training, and then your ergs with slides over non-slides.
That's interesting. I'll have to have a look at that. Sounds expensive.
They are a little bit more expensive than the normal erg. I mean, we're very lucky because I think we've got maybe 6 of them now at the club. So, but there's some, Matt might remember, I can't remember which national team it is, but there's one country where they do all their training on the RP3s. They don't use a normal erg. Wow. So I think there's a lot to be said for that.
How much? What are the percentages of water and an erg for a non-rower? Does it vary by team, or is it? Yeah, I mean, also I think I'm just a domestic rower and we're doing it around work, so our water time is a lot lower because daylight hours, coordinating work shifts. So I mean, we'd have 2 sessions on the water on a Saturday, 2 sessions on the water on a Sunday, and then the week is 3 to 4 ergs. In the summer months, that's different because you can get out in the evening and it's dark. All the practical stuff. But I think for full-time athletes, they'll be on the water every day. Not great in February in England, is it? Yeah. Rather you than me again.
Or now when it's flooded.
Or now
Yeah.
when there's you'll go off the lake. You'll
Yeah.
go off the river. Yeah. Matt, in your experience, have you worked with teams that have done all erg, or is it? I mean, it must just be mostly water, surely.
Yeah, I can't speak for sort of Olympic level or anything like that, but I think for the most part, most rowers are probably doing two erg sessions a week, at least, I'd say, and then probably some at least 6 sessions on water a week minimum, so pretty much every day, and then I think for the most part, two erg sessions, I'd say, and then maybe they might give some of the other athletes an option, so they'll say like an hour or an hour and a half or 2 hours of cardio, sort of kind of give them a bit of an option, but they just want to keep that sort of that low intensity, high volume sort of aerobic workout as well.
Excellent. So the overall theme there in terms of end stage rehab from somebody who's learning today, I've learned quite a bit, is basically don't fuss too much over the physio. Don't get too preoccupied with your physio rehab stuff. Try and get them on the water as much as possible and facilitate that, really. That's kind of, I'd get it kind of in touch with their coaches and things, which is probably something I wouldn't do normally. I'd probably go, right, well, let's look at your plank and focus on that. So that's a really good insight. I think we've gathered quite a lot of information, and massive thanks to Beccy for opening up and letting us into your journey. I don't know whether either of you have anything else you want to bring up or talk about before we wrap up.
No, I think I'm good. It's interesting hearing Matt's opinion of getting on the water sooner, whereas I've always taken the approach of making sure you can do enough on the erg. I think it's definitely something I would take forward with other rowers, and like you said, it's just being sensible and being close to the pontoon and listening to the pain scores and all the rest of it. So it's good.
Excellent. Thanks, Matt. Any final thoughts?
Yeah, I think it can be a little bit tricky to have that perfect sort of exit criteria, and I guess like any sport, really, like the demands of the sport are very unique. And I'm a firm believer in, if you want to throw, you've got to throw. So I'll give people like a throwing program if they're going to return to a sport that involves throwing, for example. And I think for rowing, like the task itself is the most important part of your rehab. But I think you need to be appropriately strong to be able to do that. So I think if you're able to complete all your gym work and that's not really giving you any symptoms, your day-to-day is really comfortable, you're not waking up with excessive amounts of pain or stiffness, then I think that's a good idea that things are quite settled, and that gives you a bit of a baseline to actually move on and have a bit of an idea on what your symptoms are like. So if you're asymptomatic with all those sort of activities, then that gives you that potential to look to add in a new activity and reassess afterwards.
No, that's great. Thanks a lot. Well, look, thanks to both of you for joining us. I'm sure everyone who will listen to this, when we publish it, will take a lot from it. I've already learned, and hopefully my rowing patients will benefit from it. So that's a great help. Thanks for your time. So we'll finish there. Thanks for watching, and we'll see you next time.